Thanks everyone for joining. My name is Peter Cohn, and today we'll be talking about spondylolisthesis. I'll try to move along as best I can, but I'll leave some time at the end for some questions. So this is what we're talking about today. This is an extra-area spondylolisthesis, or colloquially referred to as a slip. It's the translation of one vertebral body on another, and usually we're talking about an anterolisthesis, like it's pictured here, where the superior body translates anteriorly on an inferior body. And when we talk about spondylolisthesis, generally, or most commonly, we refer to the Wiltse classification to divide spondylolisthesis into different types or etiologies. And so this classification, I'll go through it real briefly now, but essentially the two main types and the types that we'll talk about most today are isthmic and degenerative types. So an isthmic spondylolisthesis is really any defect in the pars, which then results in a translation of that superior vertebral body or of that same vertebral body. So that can be a dysplastic pars. There can be a spondylolysis or a break in the pars. There can be an elongation of an intact pars, or even an acute fracture. But really, any disruption of that pars or that part of the posterior elements between the superior and inferior facets, that's going to be an isthmic type spondylolisthesis. Degenerative type is more due to disc degeneration. And as that disc degenerates, there's more micromotion at the disc, and that increased motion then leads to more motion at the facets. And over time, that causes arthritis in the facets and arthritic change and degeneration of the facets, which can lead to that same listhesis because of the change in the anatomy of the facet joints. You can also have fractures in other areas of the vertebral body, like the pedicles pictured here, which can result in a disruption of the ring and allow that anterior translation. You can also have tumors, which cause lytic changes and, again, can disrupt the ring and cause anterior translations. And then the last one, which we don't really need to talk about, right, is post-surgical, which would be an over-aggressive decompression leading to weakening of the pars, and then resulting in a spondylolisthesis. So like I said, today we'll talk about isthmic and degenerative types. Spondylolisthesis, of course, can be graded to determine or to help us talk about the severity a little more easily. So there's probably the most commonly used grade is the Myerding grade, which is pictured on the left. And you can divide the the superior end plate of the inferior vertebral body into quarters. And then if you look at where the posterior edge of the superior vertebral body sits on that end plate, you can determine the grade. So grade 1 would be a 0 to 25%, 2 to 25 to 50, etc. And then there's also the slip angle, which is pictured here. And obviously, the greater this angle, the more severe the slip. So what is a slip? And really the question is, what determines a pathologic slip? And that's something that really isn't 100% understood, but there's sort of been a lot of mostly cadaver research looking into this. So traditionally, and I think it goes back, I saw a paper cited from 1945 in a radiology journal that referred to this 3 or 3.5 millimeter translation as a sort of radiographic definition of what is an unstable slip. So any translation greater than 3 or 3.5 millimeters is considered by a lot of authors to be indicative of instability, of an unstable pattern or a pathologic pattern that may need treatment. So there was a paper by Punjabi and White that described that 3.5 millimeter translation. And then there was a paper by Posner et al. That kind of built on that, and they actually did a cadaver study where they essentially bent spines in extension to failure, and then looked at the maximum translation they could achieve prior to failure, and they found that was around a 9% translation. So they determined that kind of not anything greater than that is an unstable pattern. And then, to kind of muddle everything, Bowden and Weasel were looking at flexion extension radiographs of 40 healthy volunteers. And what they found were they had about 25% of those had static translation of greater than 3 millimeters in their asymptomatic volunteers. And so they sort of argued that, if we're having 25% of our patients have that much translation, they can't all be unstable. And then they sort of introduced that the dynamic instability that you would see on a flexion and extension view, if you had a greater than 3 millimeter change on those dynamic views, that was maybe a better definition of what's unstable, since they had only about 5% of patients have that dynamic instability greater than 3 millimeters in their asymptomatic cohort. Yeah.
Peter, I'm just going to stop you for a second.
Yeah.
It makes me very nervous when you use the term unstable. Okay.
Right.
Unstable is a term we use
in
relation to trauma and fractures, and there's a chance that this will go on to develop neurologic problems, and there's some horrible. Right. I think what you're really saying is really the Punjabi and white stuff was really trauma stuff. I think what you're really saying is what's pathologic, what's within what degree of subluxation is within the range of physiologic, and what becomes pathologic. But I wouldn't use the term unstable, because these people, you've seen a lot of degenerative spondies, and this really has nothing to do with isthmic spondies, right?
Right.
These people they're not unstable at all. In fact, you can be slipped and stuck in that position. So I would caution you to not use the word unstable when you're talking about this.
Yeah, and I agree, and I think I used it just because when you read a lot of these papers, I'll go through some more. It tends to be used kind of colloquially as this term unstable to mean fracture, or sorry, a spondylolisthesis that may do better with fusion versus not fusion. And so the term unstable kind of gets thrown around, and I guess I'm guilty of it too here.
Right. I think we need to be
but
much
I agree. I think really what we're trying to define is what is a pathologic, and I'll get to that in a second. What is a pathologic, or what defines, a pathologic slip for something that's causing patients really symptoms is what we're really getting at. And so actually that leads into my next slide. So even this paper by Posner et al., when they were determining, their checklist for instability, which again is talking about unstable, even in their checklist, they're using they have their radiographic kind of parameters, but they're also using clinical parameters as well. In this case, cauda-equina damage. But the point of me putting in this slide is that whenever you're talking about instability, or if it's pathologic, the x-ray finding really should only be part of the picture, and really the patient's symptoms and neurologic function are the other half of that picture, and you have to really use both of those clinically to determine what's pathologic. So for the talk, I'm going to divide the talk into two, and we're going to talk about degenerative spondylolisthesis first, and then I'll follow that up with some more research on the isthmic spondylolisthesis, because they really are, very different and separate entities in terms of the etiology and how we treat them. So degenerative spondylolisthesis is an acquired anterior displacement of one vertebrae over the subjacent vertebrae associated with degenerative changes without an associated disruption or defect in the vertebral ring. And when we talk about epidemiology, this was a study from the Copenhagen osteoarthritis study, and they looked at, they included, I think it was about 1,500 men and about 2,600 women who were included in the study. And they were looking for essentially the incidence of spondylolisthesis and potential risk factors for that. And they determined that in women, body mass index and the angle of lordosis was significantly associated with this, and that, of course, I mean, we're talking about degenerative spondylolisthesis, so you would think that age would have something to do with it. But they also found a pretty strong correlation, or a higher incidence in females than males in terms of who had it. In a study that was better designed to look at incidence and prevalence, this was a study across the Pacific Ocean where they had 200 asymptomatic adults who were recruited for this study, and they essentially obtained x-rays in 1990 and in 2005. And what they found in 1990 was that the prevalence of spondylolisthesis was 10%, and in 2005 it was 22.5%. And the de novo incidence during that time, during that 15-year period, was 14%. Interestingly, they also found a progression rate, meaning an increase in the slip of greater than 3 millimeters, of 30% in their study. And when they looked at their numbers, they found that they determined that their risk factors for that progression were positive sagittal balance, as measured really just from lumbar parameters, the degree of the initial slip, and the age. And also they found that older patients tended to progress less, and they attributed that to auto stabilization, which I'll kind of talk about a little bit more in this next paper. So this was a prospective cohort of 40 patients, and they had 5-year follow-up with an average age of 55, and all the patients in the cohort started with at least a 5% or greater slip. And the patients initially presented almost 100% with back pain, half of them had radiculopathy, and 10% had weakness or claudication. And they again showed this 30% progression, and the progression was about 15% on average. But what they found in their paper was, A, that function and how people felt about their symptoms did not really correlate with progression of the slips. And they also found that a lot of these patients demonstrated what they call auto-stabilization, where as the disc degeneration progressed, there was less disc height, more osteophytes, and ossified ALL, and all that contributed to less motion at the joint, and actually it had a protective effect in terms of slips not progressing. So this is just kind of an image of their data. So on the left, you can see that obviously their progressive group had a greater percentage in slippage at the final exam, while the non-progressive group stayed the same. But if you look at their JOA scores from the beginning and the end, pretty much everyone got worse whether you progressed or not. And so there wasn't a whole lot of, and I shouldn't say everyone, but there wasn't a whole lot of, there wasn't a significant correlation between progression of the slip and worsening symptoms. And so then this was another study from the same group, I believe, looking again at this phenomenon of auto-stabilization, or in this paper called restabilization. And when they followed patients after 10 to 18 years retrospectively, they found that over time, the angular displacement on the flexion extension views, so the amount of displacement dynamic instability you could, or the amount of angular instability actually decreased over time as the patients became more arthritic and had less motion at that segment. And with that decrease in motion, they found a significant decrease in back pain as that motion was stabilized, and maybe a little bit of leg pain. But really, this kind of drives some of that idea that these can be kind of self-contained, and as your arthritis or degeneration gets worse, it actually has a protective effect. So, we're a spine surgeon, so we're going to talk about surgery. So in terms of operative indications, or when do we consider an operation for patients with spondylolisthesis. Obviously, not everyone with spondylolisthesis needs surgery. In fact, most of them don't, and most of them are asymptomatic. But if patients have radicular pain or neurologic symptoms greater than 12 weeks, failure of non-operative management of those symptoms, confirmation of stenosis in association with those symptoms on MRI or CT or advanced imaging, or progressive neurologic deficits that are getting worse, those can all be indications for surgery. And additionally, you could argue in some cases that if there's a very high-grade slip, that may be an indication on its own. So one of the oft-cited and discussed papers discussing surgery versus non-operative treatment for spondylolisthesis is the SPORT study or SPORT trial, which was a randomized controlled trial with basically operative and non-operative treatment for spondylolisthesis. And in this case, they were only talking about degenerative spondylolisthesis. The real key in this trial is to look at the as treated numbers. There was a 33% crossover from the non-operative to the operative arm, whereas 97% of the patients offered surgery ended up undergoing surgery. And they looked at outcome scores, pain, bodily function, and all these patients were patients with with spondylolisthesis who had failed non-operative treatment. And the surgery and what they had done was really left up to the surgeon. And what they found was that over those initial 4 years in the study, that there were sustained improvements in function, ODI scores, and pain scores. And so this really was this really was a good indication that, yes, surgery was helpful and we were doing the right thing by operating on these patients. And then they followed these results for 8 years, and they showed that these benefits were still sustained even after 8 years in the ODI scores, and that those benefits were still significantly better. In this study, they do divide, especially in the initial study, they divided out what types of surgery the patients had. In this 8-year result study, there was a group of patients who had a decompression surgery alone without fusion, but they didn't have enough numbers to really include them in the analysis. So for the most part, these results reflect patients who had a fusion surgery versus non-operative. But then that leads to the question of, do patients with degenerative spondylolisthesis need a fusion or not, or do they really just need decompression to help with their neurologic symptoms? So this was a paper by Nancy Epstein, who was looking at this, and she reviewed 290 patients. There were all her patients, and she did an average decompression of 3.5 levels. She followed them for 10 years. In her group, in this operative group, if patients had greater than 4 millimeters of dynamic translation or a greater than 10-degree angular deformity, they had a fusion, so they were not included in this group. So these were what some would call or what these would call, some people would call maybe a stable spondylolisthesis. But at any rate, she had a 2.8% rate of instability after her laminectomy, which later required a fusion, and her total rate of reoperation was around 16% for either instability or recurrent stenosis. But overall, decent results, and did show that laminectomy is an option for these patients, and that not all spondylolisthesis on X-ray needs to be fused. In another group, they looked at a prospective review of 40 patients who were treated with laminectomy for low-grade spondylolisthesis, and they followed these patients for 3.5 years. Again, if they had dynamic translation greater than 3 millimeters on flexion extension views, then those patients had a fusion. They were not included in the study. But in their group of low-grade spondylolisthesis treated with laminectomy alone, they actually had a reoperation of 37.5%, and most of those reoperations were done for significant mechanical low back pain post-op, and quote-unquote presumed instability. And if you look at their scores for the patients who had reoperations and non-reoperations, obviously the patients who are getting reoperated on had worse ODI scores. So they went back and they looked at their numbers to see who were these patients who needed revision surgery, and they found a few risk factors that contributed to that. So if patients had motion at the spondylolisthesis of greater than only 1.25 millimeters in flexion extension views, those patients had a 54% increased risk of reoperation. If the disc height was greater than 6.5 millimeters, they had 45% increased risk in reoperation, and facet angles greater than 50 degrees also had an increased risk of reoperation. And if you had all three of those factors, you had a 75% risk, and if you had none of those factors, you had a 0% risk of or percent chance of reoperation. So this helped sort of define maybe some possible parameters to look at when considering decompression versus fusion, and who could do well with the decompression alone. And then if now we're talking about fusion and we have some parameters that look at, maybe these patients would do better with the fusion, how did they do? Or this was just another paper, by Herkowitz, that also looked at fusion versus not. So this is a randomized controlled trial with 3-year follow-up on single-level spondylolisthesis. Unclear exactly how the spondylolisthesis was graded preoperatively, but the groups were alternately assigned either a fusion an uninstrumented fusion or no fusion. And there was a 36% pseudoarthrosis rate in the study, and only 9 of the patients who had a pseudoarthrosis had good or excellent results. But what they found was 28% of patients with fusion had a slip progression, whereas 96% without the fusion had a slip progression on average 3 millimeters. So the conclusion here was that a fusion is better than no fusion. And then the question then is, did having a fusion lead to improved outcomes? So this is long-term follow-up with those patients. And patients who had a fusion had 86% good or excellent results, whereas patients with a pseudoarthrosis had a 56% good or excellent results. And so the conclusion was, obviously a solid fusion will do better than pseudoarthrosis long-term. And so if now we're thinking about how are we going to increase our fusion rates to avoid the pseudoarthrosis, which seems to have worse outcomes, what is the best way to get that fusion? So this was a Fishgun paper, randomized controlled trial in 1997. Again, single-level degenerative spondylolisthesis, and all the patients had neurogenic claudication or severe radiculopathy, and almost all of them had significant axial back pain. And the patients were randomized to either an uninstrumented fusion or pedicle screw instrumented posterior lateral fusion, and all the patients had decompression in addition to the fusion. And in their paper, the fusion rate was significantly higher in the instrumented group. So I think if you go back here, you can see the 83% versus 45%. But the clinical results did not correlate with the instrumentation. So even though there were greater fusion rates with screws, the clinical results did not necessarily mesh with that. So, that raised some more questions. Instrumentation helps with the fusion. Does it really help overall? To be determined. In another New England Journal article, randomized controlled trial looking at laminectomy and fusion versus laminectomy alone. They had 66 patients, all with less than 3 millimeters of translation on flexion and extension views with grade 1 spondylolisthesis. And they looked at a few outcomes, but significantly they looked at the risk of reoperation over time. and they found that there was a significantly increased risk of reoperation for patients with the decompression alone. They also found when they looked at SF-36 scores that there was actually a sustained significant benefit in the fusion group for the SF-36 scores, and that benefit actually met the minimal clinically important difference. So they did. It's the New England Journal, so they sort of conceded that the fusion was actually beneficial in that regard. The ODI scores did not show that same significant benefit. And then, so moving on to, okay, we have a patient, maybe they have more translation on dynamic views. We're thinking the patient may benefit from a fusion, and we've talked about instrumented fusions, getting better fusion rates. So what's the best way to instrument, or how are we going to maximize the efficacy of our surgery and our technique? So this was a meta-analysis looking at 4 randomized controlled trials and 3 observational studies. Comparing posterior interbody fusion, or sort of PLIF, versus posterior lateral fusion alone, and also versus a PLIF with a posterior lateral fusion. In the 3 groups, every group had pedicle screws. The difference was either you had an interbody or not, or you had posterior lateral fusion mass or not. And they looked at adults only. But there was some question if one of the trials that they included some isthmic spondylolisthesis cases, so that might have muddied the data a little bit. But what they found was that there was moderate evidence that the interbody fusion offered significant improvements in terms of satisfaction, complication rates, fusion rates, and reoperation rates compared to posterior lateral fusion alone. But when they looked at interbody with a posterior lateral fusion versus a posterior lateral fusion, there really wasn't any significant difference. So they weren't really exactly sure how to explain that. Their main theory is that as to do the posterior lateral fusion, it requires a little bit more dissection to get out to the full transverse processes and to get your bone graft there, and maybe that affected the outcomes. So this was another similar meta-analysis, and this one was looking specifically at T-lifts versus posterior lateral fusion. And again, they found that the interbody improved the fusion rate significantly. There were improvements in back pain and ODI scores, but there were no real, at least significant changes in health-related quality of life scores. And additionally, the TLIF had similar results in terms of EBL, infections, and that sort of thing. So still up in the air, but there is maybe some evidence that an interbody does improve the outcomes. So conclusions for this kind of degenerative portion of the talk: decompression alone for quote-unquote stable slips or spondylolisthesis with dynamic instability, maybe less than 3 millimeters, or however you want to quantify it. But decompression alone for a more stable slip and stenosis is a reasonable option. And then for slips with more motion or for back pain, a fusion seems to do better than a non-fusion. And that fusion, when you perform a fusion surgery, obviously a fusion will do better than pseudoarthrosis, and instrumentation tends to improve fusion rates. Thus, for us at least, if we are going to fuse, instrumentation for the slip has really become the standard of care. And then interbody grafts may increase our fusion rates. Some of the data suggests that potentially an interbody without posterior lateral fusion may do better. So we're going to shift gears a little here and talk now about isthmic spondylolisthesis. Again, this is any I'll show the definition in a minute. Just for anyone who needs a refresher, this is the PARS. When we're talking about isthmic spondylolisthesis, a lot of times we're talking about spondylolysis leading to spondylolisthesis, so an injury to the pars causing that disruption of our posterior elements and allowing that anterior translation of the vertebral body. So isthmic spondylolisthesis, again, the definition, it's the anterior translation of one lumbar vertebrae relative to the next caudal segment as a result of an abnormality in the pars interarticularis. That can cause symptoms, variable clinical symptoms, including back pain and or lower extremity pain, and may include a varying degree of neurologic deficits at or below the injury. So incidence for isthmic spondylolisthesis, this was a study looking at 500 school-age children, and they were followed all the way to adulthood. What they found is that initially there was overall there was a 6% incidence of spondylolysis, and then of those patients, of the younger patients, there was a 68% incidence of a spondylolisthesis with that spondylolisthesis, and in the older patients, a 74% rate of slip with the spondylolysis. Most of these slips did not progress, so it was possible, and of these initial spondylolysis found, 92% of these pars defects had spina bifida occulta. So what is the natural history of these patients with spondylolysis? So this was a study that followed 30 patients from an initial study for 45-year follow-up. And they had 8 patients with unilateral pars defects and 22 with bilateral defects. They had 3 of the 8 unilateral defects healed and none of the bilateral defects healed over the course of the study. In terms of progression to a spondylolisthesis, 0 progressed in the unilateral group, and the bilateral group, 50% of those patients did have a progression. And the mean slip, if there was a slip, was 24%, although one slipped it to as much as 39%. But the interesting take home here is that when they followed these patients and compared their SF-36 scores to an age-matched cohort, they're basically the same. So, in terms of, for most patients who have these defects, it's really not something that necessarily needs to be followed or really monitored. So in terms of, what correlates with spondylolisthesis in terms of other radiographic parameters, this was the study looking at 40 patients and comparing them with age-matched controls. And they found that pelvic incidence does correlate with the presence and the severity of the spondylolisthesis, at least on presentation. So when it was found, there was an increase, pelvic incidence did correlate. However, in terms of progression of spondylolisthesis, pelvic incidence did not predict progression. And the best predictor of progression of a spondylolisthesis, at least in this study of 36 patients, was found to be the degree of the initial slip. So if the slip was worse when it was first found, those slips had a higher rate of continuing to slip. So for these isthmic spondylolisthesis patients, one of this randomized controlled trial looked at 111 patients and compared surgery versus conservative management. They had, of the surgeries that were performed, 40 were uninstrumented fusions, 37 were instrumented fusions, and none of the surgical procedures had a decompression component. These are all fusion surgeries. And then 36 patients underwent just physical therapy. There was minimal crossover in this study. They didn't look at radiographic parameters or fusion rates, and they were just looking at overall outcomes and disability. And really the key here, and one of the differences when we talk about isthmic spondylolisthesis, is that even in patients who have only low back pain and no neurologic symptoms, these patients who underwent surgery actually still did significantly better with surgery, even though the traditional thing we tell medical students is we don't operate on back pain. In some cases, we do operate on back pain, and this may be one, or this is one.
Peter?
Yeah.
That study is a great study, and I love it because it does help you with that problem. But you got to know that part of their inclusion criteria are people who failed a full course of physical therapy.
Right.
So what they're really saying, so they're not saying that surgery is better than physical therapy. They're saying
right. It's better than
continue physical therapy once that's failed.
Yeah.
Is doing the same thing over and over again and expecting a different result is insanity.
Right.
But so that so don't think that means out of the gate you should recommend surgery for people with back pain.
Oh yeah, right.
After they fail physical therapy, then surgery becomes a better option.
Perfect. Thank you for clarifying that. So the disability scores improved significantly at 2 years compared to non-operative management. And again, there's no real breakdown between how the surgeries were done, but the conclusion essentially was the surgery did better than continued non-operative therapy management. So this was a meta-analysis looking at 36 different studies. Really, they only included 6, though, that had appropriate 2-year follow-up. And they were looking at treatment options and types of fixation for surgical intervention for isthmic spondylolisthesis specifically. And what they found was that in terms of using instrumentation or not, that instrumentation did have a higher success rate, that 84 versus 64, that doing a laminectomy or not doing a laminectomy in these 6 studies did not matter in terms of the % success rate, and that they also found that having anterior column support or inner body support, either in combination or alone, tended to improve the success rates versus a posterior fixation or fusion alone. And then when they looked at their fusion rates, that they sort of reiterate the same thing, where that having a either combined or having a combined approach for fusion tended to improve fusion rates, and that those were the highest fusion rates, and that fixation obviously, or not obviously, but as we've seen already, fixation improved fusion rates as well, and obviously smoking decreased fusion rates. And so the conclusion of this meta-analysis was that anterior column support was an important factor and tended to improve outcome scores, and they recommended considering a combined approach. So in terms of guidelines, from NAS and what we have, their recommendation are that for isthmic spondylolisthesis is that posterior lateral fusion and 360 or anterior posterior surgeries are recommended to improve the clinical outcomes in patients with low-grade isthmic spondylolisthesis. So that's a grade A recommendation. 300 or AP fusion is recommended to provide higher fusion rates compared to posterior lateral fusion alone. And there is conflicting evidence whether that anterior posterior fusion really provides better outcomes than posterior lateral fusion alone. But fusion, good for isthmic spondylolisthesis. And then in patient, this is a little more getting in the weeds, but for patients who are undergoing anterior fixation, doing percutaneous screws can lead to shorter hospital stays, but there's no evidence that that improves outcomes overall. So conclusions for isthmic spondylolisthesis. Adult isthmic spondylolisthesis is much different than degenerative, and fusion is better than non-operative, continued non-operative management, even if it's for a significant back pain component. And adult isthmic spondylolisthesis seems to respond better to anterior column support, so maybe that's an indication, although we're still looking at that. So this I just included kind of for fun because we were talking about this in our own spine conference on Wednesday. And this came up because there's a patient coming up on the schedule who's a younger patient who has a spondylolysis without a spondylolisthesis, and we were trying to discuss what is the best mode of treatment for a patient like that. And so this was a study in Europe where they looked back at young patients. I think they were all less than 30, or they were all in their teens on average, and they were treated for spondylolysis or low-grade isthmic spondylolisthesis with either a cerclage wire for direct repair versus a fusion, and that could have been a 1 or 2 level fusion, uninstrumented. And then they looked at the outcomes for these patients. So this is just a breakdown of those two groups, and they were similar in terms of the group makeup. And in terms of the outcomes, there really was not a significant difference other than the ODI scores in the fusion group. In the long-term follow-up, actually did have significant improvements in that fusion group compared to the fixation group. But really, part of the point of the study, they looked at a lot of different parameters, and what they found was that in the direct repair group, those patients still had disc degeneration on MRI studies, so there wasn't necessarily a protective effect that they found of doing a direct repair versus a fusion in terms of protecting arthritis at that level. They didn't really flesh this out in the discussion or anything, but they did find that, obviously comparing a fusion to the direct repair, there was some improved motion comparative between the two groups if you look at the L5S1 level, but they still found that you still lost motion obviously over time at that L5S1 level. So they kind of pointed to that as another area where the theoretical advantage of a direct repair didn't really pan out in the results. But overall, the results were essentially that the outcomes were about the same with the direct repair versus a fusion in this long-term follow-up. So overall conclusions, the baseline prevalence of degenerative spondylolisthesis is around 10%, and it's certainly not always symptomatic, but there's a 30% risk of progression. For isthmic spondylolisthesis, the incidence is around 6%, and there's spondylolysis, is around 6%, and there can be a concomitant spondylolisthesis in about 75% of these patients. Degenerative spondylolisthesis can undergo auto-stabilization over time with reduction in symptoms, particularly back pain symptoms, and the slip itself does not necessarily correlate with the symptoms. The greatest predictor of progression of a slip is the initial amount of translation on presentation, and other factors such as facet orientation and disc height may be important when thinking about your surgical treatment options. So decompression alone for quote-unquote stable spondylolisthesis and stenosis seems reasonable. For more dynamic or more mobile spondylolisthesis or back pain, fusion seems to be greater than non-fusion. Fusion does better in pseudoarthrosis, and instrumentation improves fusion rates, and interbody grafts may increase fusion rates and outcomes. And then for adult isthmic spondylolisthesis, it's really a different entity, and surgery in the form of fusion tends to do better than non-operative treatment, even if there's a significant back pain component. And adult isthmic spondylolisthesis tends to respond better to anterior column support. And that's what I have. So at this point, I'll open it up to any questions or comments.
Hey, Peter, that was really great. Nice overview, nice review of the literature. Some of that literature is getting a little long in the tooth, but
yeah,
still useful. Hey, the only thing you didn't cover, which I think is really important, especially on the fellow level, is you didn't talk about sagittal plane and reduction.
Yeah.
And the difference between a kyphotic slip and a rotational deformity versus a translational deformity, and the correlation between high pelvic incidence and the incidence of isthmic spondylolisthesis, and then when the compensated isthmic spondy versus the locally decompensated but globally compensated spondy versus the decompensated spondy plus that is also globally decompensated, and when those, which of those you might want to think about doing some type of reduction, what type of reduction, in terms of, and there's pretty good articles, I think Rosalie or Schwab, and if you're going to add to this talk, you might want to just put a slide or two talking about their classification of the Schwab classification of spondy, and what they feel about the need for sagittal plane reduction or translational reduction.
Gotcha. Yeah, I think we pulled all those because when we did our talk recently, we had all those. I just didn't want to make this get too cumbersome, but that's definitely something we could put in the future.
Pete, I agree. I mean, the talks were spectacular, very comprehensive, well done as always. And I think adding what Dr. Gelb was describing brings in, an added level of complexity to this talk, and really sort of gets into the granularity of decision making, because not everybody, one degenerative spondy or isthmic spondy is not the next, right? They all have little nuances that we have to pay attention to. And often we don't communicate that, as we decide on our decision making. I think the other thing that would be interesting to sort of look at with the evolution of minimally invasive techniques are the role for MIS surgery versus open surgery, right? And with the evolution of lateral-based surgery, how that is also becoming a role, or an option, for the treatment of both isthmic type and degenerative spondylolisthesis. So I think some thoughts given to those techniques, because they're becoming much more popularized. It's really interesting, I think, that although we're very purist, as you guys all know, and we're typically doing interbody support for I-spondy patients compared to degenerative spondy, I think our group is fairly consistent in recommending interbody support under very, very specific circumstances, right? I think Dr. Gelb already alluded to, somebody that is decompensated, multi-level spondies, patients that are kyphotic or rotatory listhesis may fare better, or poor fusion hosts, or have severe foraminal disease, may require interbody support, for the degenerative spondy population. So we are, in somebody that is not significantly decompensated, has a low-grade spondylolisthesis, is a good fusion host, is not kyphotic, locally, regionally, or globally, they're getting a posterolateral fusion in our hands, as you guys all know, I think by now. It's a fairly straightforward procedure. I think the only other thing that everybody needs to be sort of cognizant too, as you move on to wherever the next stage in your career in hospital-based employee or academics, or even, if you're a private group, is that everybody looks at your costs, right? And anytime you do an interbody fusion, you're going to add cost, right? It's going to take more time in the OR, potentially more EBL, although the data doesn't necessarily support that. Potentially more complications, although the data doesn't necessarily support that, as like an A-level type of recommendation. But the reality check, especially when you're in your learning curve, you have to be considered in that. An interbody graft, depending upon what graft you're using, how many, if you're doing a PLIF or a TLIF, that can add between $3,000 to $7,000 worth of added cost, right? And if it doesn't necessarily get your patient out of the hospital that same day, it's going to be a really, really tough time to show the value in your procedure, right? So I think just when the data doesn't drive you in such a directed, decision making for treatment, you just have to think about that, what you're doing. But But the last question that I have, and I'm just asking if you or comment in your literature search.
Mm-hmm.
I think the Zoe paper is an interesting paper to me, from a predictive analytics to figure out who needs a fusion versus non-fusion for spondies,
Mm-hmm.
looking at the height, the
Right.
degree of listhesis, and the facet topography, right? Did you see anything in patients that have multi-level spondy, and maybe the lower level spondy or the upper level spondy does not necessarily meet that criteria, but yet it's on top or below a fusion, right? So if you have somebody that has maybe a 2-level spondy radiographically, and one is really, really apparent, the other is just like, really have to stare at it.
Right.
Have you seen any articles in your search that come across those multi-level spondies looking at that with more scrutiny?
You know what? I don't recall anything that mentioned that or that looked at that specifically. But to be fair, I wasn't necessarily looking for it because I was trying to kind of focus on some of the bigger papers. But yeah, that would be interesting because that would definitely fit into what are these risk factors, and it's definitely a problem we run into a fair amount. So I agree. I could take a look for you and see if there's anything out there.
Has anybody, Dan Gelb or anybody else, have you guys seen anything on that?
No.
No.
Yeah. And once again, doing a 2-level fusion is a lot different than doing a single level fusion, right? For some people. So once again, just have to be cognizant of all those issues, I think. But great job, Pete. Spectacular.
Thanks.
Anybody else have any questions, concerns, comments?
Pete, excellent job. It's Eugene. Great review. I agree with everything was said. So just more specific, doing your literature reading, we have that 16-year-old male. What would you offer that patient yourself? How would you go about thinking about it, explaining it to the family? Because I'm having a difficult time. This is about telehealth visits that I've had with a family.
So, I mean, I think no matter what you do, you're supported. But I think what I would do, at least based on this paper, I mean, they had 15-year follow-up with no adjacent segment issues and great outcomes. I'd probably do a fusion.
Okay, I would respectfully agree with that. I think these data points are based upon no measured outcomes, right? No disease specific or non-disease specific outcomes measures, right? I think if you go back and look at your pseudarthrosis rate. Wasn't it? Did they have a?
I could bring up the paper. I don't know. It was really low. It was almost, I want to say it was like 0.
Oh, maybe when I looked at this, go back to that. I didn't read the paper, but this is based upon data from the 1980s, right?
Right. Yeah, because
that patient that Eugene had no spondylolisthesis.
Right.
Had a perfect disc space. Right.
Right. I mean, I think what this paper showed was even with the direct repair, I mean, the presumed advantage of doing a repair is, you avoid a fusion and you avoid potential problems with adjacent segment and potentially you maintain motion there. But I think what this paper showed is you don't really maintain a lot of motion. There's still disc degeneration and, the outcome scores are similar. At least, from their data. So I think, I guess for me, I'd love to try a screw to see what that's like. but probably what's best for the patient, in terms of having a more predictable result operatively, I feel like I would do better with a fusion.
Can always do a fusion.
Yeah.
You had to.
Yeah.
Yeah, I talked about that, Dr. Ludwig, but it's, this gets outside of the scope of this talk, but, the parents are always worried about a second surgery in one of their kids, right? So I told them there's a revision rate, possibly with a direct repair. So they're debating about that.
Mm-hmm.
Yep, I agree.
Yeah.
No question. Concerns.
Yeah. Excellent talk, though, Peter.
I thought this paper was interesting though, because they were doing the direct repair for really slips to almost reduce spondylolisthesis with the wire. It sounded like.
Well, that's my
Yeah.
point. That's my point. That this group of patients is not the patient that was described from the other day. All right, guys. Have a great day. Thank you so much.
All right. Thanks.
Thanks, Peter.